Welcome back to the deep dive. Today, we are shifting gears a bit. We're going into full, high-stakes exam mode. We've pulled together a massive stack of resources, Miller's, the latest ICU protocols, Harrison's, Guyton's physiology, even the KDIGO guidelines, to tackle a topic that is, well, it's absolute bread and butter for the anesthesiologist, but also a notorious stumbling block in exams.
It absolutely is. We're talking about the kidneys, specifically acute renal failure, or as we should really be calling it now, AKI, and chronic renal failure, CRF.
And just to set the scene for you listening, we are framing this a little differently today. You are the senior MD anesthesia faculty, the examiner, with the glasses perched on the end of your nose.
And you're the postgraduate student.
I am the postgraduate student preparing for my Gujarat University MD exams. The entire goal here is to get me, and by extension everyone listening, completely Viva ready.
That's the perfect mindset to have. Because let's be honest, the kidney is often the silent victim of surgery. It doesn't really complain, not loudly anyway, until it's far too late. And in the exams, whether it's a 20-mark long question, a short note, or you're sitting at the Viva table, you are guaranteed to face a question on renal, physiology, and pathology.
The stakes are incredibly high, aren't they? I was looking through the source material and I saw a stat, I think it was in the ICU protocols text, that mention mortality rates of 50 to 60% in ICU settings when acute kidney injury is involved. That is just a staggering number.
It is a major, major killer. And anesthetists have to understand this inside and out because these patients, the ones with significant renal failure, are essentially ticking time bombs. They have multi-system involvement. We're talking anemia, coagulopathy, severe acid-base issues.
So our mission for this deep dive is to build a structured, examiner-approved answer for that classic question. Discuss the pathophysiology and anesthetic management of renal failure.
That's right. If you can master this topic, you can handle almost anything they decide to throw at you on exam day.
Okay, fantastic. Let's get into it. And we have to start where every good exam answer starts, with the definitions. But it's not just acute renal failure anymore, is it? The terminology has shifted, and I have this feeling that if I use the wrong word in the exam, I'm going to get a frown from the examiner.
You might, and you should be precise. This shift in terminology isn't just pedantic name-changing. In the exam, if you want to impress, you need to show you're current. We used to say acute renal failure, or ARF. The standard now, the correct term, is acute kidney injury, or AKI.
So why the rebrand? Is it just semantics, or is there a deeper reason?
No, it's a very important conceptual shift. The term failure implies a kind of finality, doesn't it? It suggests the organ has just stopped working. It paints a picture of a binary state. It either works or it fails.
Right on or off.
Exactly. But the expert consensus, and if you look at the source guidelines like Rifle-E and KDIGO, they all emphasize that renal dysfunction is a spectrum. It's a continuum. Small decrements in function, these little injuries, happen long before you get to the point of overt failure.
So injury is a more sensitive term. It captures that early dysfunction. It's almost like a call to action to intervene before you hit that wall of failure.
Precisely. It allows for and it encourages earlier intervention. The whole point is to catch it at the injury stage to prevent it from ever becoming failure.
Okay, that makes perfect sense. So how does that contrast with chronic renal failure, or CRF? That's often used interchangeably with chronic kidney disease, or CKD.
It is, and the definition there is very specific, particularly regarding time. And you absolutely must, cite the time component to get the marks in the exam.
Okay, so what is it?
CKD is defined as a glomerular filtration rate, a GFR, of less than 60 ml per minute per 1.73 meters squared for more than 3 months.
That 3 months part is the key.
It's the absolute key. It implies a chronic process. It implies irreversibility.
And that really is the fundamental distinction for us as anesthetists, isn't it? AKI is potentially reversible if you catch it and treat the cause, but CKD is a progressive, irreversible loss of nephrons. There's no going back.
Correct. Your goal in managing an AKI patient is to rescue the kidney, to pull it back from the brink. Your goal in a CKD patient is to preserve what little function is left and, crucially, to manage the enormous systemic fallout of that chronic failure.
Okay, that's a brilliant foundation. Let's dive deeper into the classification of AKI. This is exam core material. If I'm asked in Aviva, classify acute kidney injury, how do I structure that answer?
You stick to the classic triad. It's simple, it's logical, and it never fails in an exam. You break it down into pre-renal, intrinsic, and post-renal.
Right. Let's break those down one by one. Pre-renal seems to be the one we see most often in the surgical setting.
By far. Pre-renal is, at its core, a functional problem. The kidney tissue itself, the parenchyma, is actually intact and healthy. The problem is perfusion. The kidney simply isn't getting enough blood flow.
So what are the classic causes?
Think of anything that reduces blood flow to the kidney. Hypovolemia from hemorrhage in a trauma patient, severe dehydration, profound hypotension from a low cardiac output state like heart failure, or the massive vasodilation you see in sepsis.
So in theory, if I can fix the underlying perfusion problem, if I give fluids, if I start pressors and get the blood pressure up, the kidney should start working again almost immediately.
That is the absolute hallmark of pre-renal AKI. It is reversible with the restoration of perfusion. The tubules are essentially just, you could say, hibernating. They're trying to conserve volume and salt to save the body.
But, and I'm guessing there's a big but here.
There's a very critical but. If you leave a pre-renal kidney ischemic for too long, that functional problem transitions. It becomes a structural one.
It transitions into intrinsic failure.
Exactly. Now you're in a much more dangerous situation. This is where the damage is inside the kidney. And the most common cause in our line of work, the one that follows prolonged ischemia, is acute tubular necrosis, ATN.
ATN, that's a huge buzzword in the exams. What is actually happening at the cellular level?
Well, it can happen in two main ways. The first is when that pre-renal state goes on for too long. The ischemia is so prolonged that the tubular cells, which are very metabolically active, run out of oxygen and start to die. Necrosis.
In the second way?
Direct toxicity. It could be caused by nephrotoxins. In your exam answer, you should list some examples. Think aminoglycoside antibiotics like gentamicin, IV contrast dye, or in major trauma or crush injury cases, myoglobin from rhabdomyolysis. These substances are directly poisonous to the tubular cells.
Okay, so pre-renal is a flow problem, intrinsic is a filter problem. That leaves post-renal.
Right. The plumbing is blocked. It's an obstruction to urinary outflow.
What are some examples?
The classics are kidney stones, benign prostatic hyperplasia BPH in an older male patient, or, and this is an iatrogenic one, accidental surgical ligation of a ureter, even just a blocked or kinked urinary catheter.
And the anesthetic relevance of that last one is huge.
Absolutely. Here is a critical practical tip for you. Always, always rule out a post-renal cause first. If your patient is oliguric in the PACU, don't just start blasting them with fluids or reaching for diuretics until you have physically checked that the Foley catheter isn't kinked or blocked.
It's the easiest thing to fix.
It's the easiest thing to fix, and it's incredibly embarrassing if you miss it and the patient gets a huge fluid bolus they didn't need.
That is a great pearl of wisdom.
Yeah.
Now, I want to get a bit deeper into the pathophysiology of ARF, specifically what the sources call the ischemic cascade. This seems to be where a lot of people, myself included, can get tripped up on the why of it all.
And this is very high-yield physiology. Getting this right shows a deep understanding. So when the kidney becomes ischemic, the first thing that happens is a drop in perfusion pressure. This triggers a powerful intrarenal vasoconstriction, sort of a protective spasm. But the real damage, the necrosis, happens in the tubules.
Are all parts of the tubule affected equally?
No, and that's a key point. It's primarily the proximal convoluted tubule and the thick ascending limb of the loop of Hemel.
Then why them specifically?
Because they have incredibly high metabolic rates. They are constantly actively pumping ions, sodium, chloride, potassium. It's an energy-intensive process. So they have huge oxygen demand. They are the first cells to die when oxygen delivery drops.
Okay, so these metabolically active cells die, and then they slough off into the tubular fluid.
That's exactly right. They die, detach from the basement membrane, and slough off into the lumen. And this causes three distinct simultaneous mechanisms that lead to the drop in GFR.
What's the first one?
The first is tubular backleak. With the cells gone, the tubular wall is no longer an intact barrier. It's leaky. So the filtrate that was formed by the glomerulus just leaks back out of the tubule and into the interstitium instead of flowing on to become urine.
So GFR might seem okay at the glomerulus for a moment, but no urine is actually being produced because it's all leaking out.
Essentially, yes, it contributes to the oliguria. The second mechanism is obstruction by casts, that cellular debris that slowed off clumps together.
The muddy brown granular casts you see on urinalysis.
The very same. That's a key phrase for your Viva. These casts physically plug the tubules from the inside. This increases the pressure upstream of the blockage, the intratubular pressure. That pressure opposes the force of glomerular filtration, so GFR drops even further.
A physical blockage. And the third mechanism.
The third is a perpetuation of that initial vasoconstriction. It becomes a vicious cycle. The ischemic tissue releases potent vasoconstrictors, like endothelin, and it produces less of the crucial vasodilator, nitric oxide. So the kidney basically clamps down on its own blood supply, worsening the ischemia.
That really paints a clear picture of why maintaining mean arterial pressure, or MAP, is so incredibly critical intraoperatively. You're fighting to prevent that whole cascade from ever starting.
You are fighting physiology? Absolutely. Every millimeter of mercury counts.
Okay, let's move on to the clinical features. We mentioned oliguria. For an exam answer, what are the specific numbers we need to quote?
Right. Be precise. Oliguria is a urine output of less than 400 ml per day, or more usefully in the perioperative setting, less than 0.5 ml per kilogram per hour.
And anuria.
Anuria is less than 100 ml per day, and if you see anuria, you should be thinking of something catastrophic.
Like what?
Complete bilateral obstruction, or a vascular disaster like bilateral renal artery thrombosis or widespread cortical necrosis. It's a very ominous sign.
But here's a potential trap, right? Can't you have renal failure with a normal urine output?
You can, and that's a brilliant point to bring up. It's called non-oliguric, or high-output renal failure. You can see this particularly with certain nephrotoxins. The kidney is making a large volume of urine, but it's poor quality urine. It's just dilute filtrate. It isn't clearing any of the waste products.
So volume doesn't always equal function?
Never. Don't be reassured just because the urine bag is full. You must look at the biochemistry. What is the creatinine doing?
That's a perfect segue. Let's talk investigations. This is an exam favorite. The examiner asks me, how do you distinguish pre-renal failure from ATN using laboratory tests?
This is the liquid biopsy question. You need to be able to logically explain how you would analyze the urine. Think about what the kidney is trying to do in each state. In pre-renal failure, the kidney thinks the body is profoundly dehydrated. So what is its primary physiological goal?
To hold on to sodium and water for dear life?
Exactly. The tubules are working overtime, so the urine sodium concentration will be very low, typically less than 10 milliequivalents per liter. And because it's frantically reabsorbing water, the urine that is produced will be highly concentrated. You'll see a high urine osmolality, greater than 500.
Okay, that's pre-renal. And in ATN?
In ATN, the tubules are dead. They're necrotic. They can't reabsorb anything. So salt and water just pour out into the urine. The urine sodium will be high, typically greater than 20 or even 40, and the kidney loses its ability to concentrate, so the urine will be dilute or isosthenuric, roughly the same concentration as plasma, around 300.
And this brings us to the most elegant test to differentiate them. The fractional excretion of sodium, or FeNA.
The most discriminating test, yes. You should know the formula, but more importantly, know how to interpret it. A FeNA of less than 1% is the hallmark of a pre-renal state. It means the kidney is reabsorbing more than 99% of the filtered sodium. It's working hard to save salt.
And a FeNA greater than 1%.
A FeNA greater than 1, and especially greater than 2%, strongly suggests ATN. The tubules are damaged, and they are wasting salt. They can't hold on to it.
That is absolute Viva Gold. Before we leave investigations, the sources mention some of the newer biomarkers. NGAL and cystatin C, are these important to mention?
I think it shows you're well-read. You should mention them as novel markers. Explain that creatinine is actually a pretty poor lagging indicator. It only starts to rise significantly after you've already lost 50% of your GFR.
So it's late to the party.
Very late. A marker like NGAL, which is neutrophil gelatinase-associated lipocolin, goes up much, much earlier. It signals structural injury to the tubule, often hours or days before the creatinine even starts to budge. They're becoming more common in ICU protocols for early detection.
Excellent. Okay, let's pivot and shift gears to chronic renal failure. We've established it's a progressive, irreversible condition. What are the big causes we're likely to see in the pre-op assessment clinic?
The number one cause, by a long shot, is diabetes mellitus. It accounts for something like 45% of all cases of end-stage renal disease. Number two is hypertension.
The two most common diseases in modern medicine.
Exactly. After that, you have a long list of other causes, glomerulonephritis, polycystic kidney disease, and so on. But diabetes and hypertension are the giants.
Now, the pathophysiology here is slightly different from AKI. The sources describe the intact nephron hypothesis, or the hyperfiltration theory. Can you walk me through that?
It's a fascinating and ultimately tragic process. As nephrons are progressively destroyed by the underlying disease, the remaining healthy nephrons don't just sit there, they adapt. They hypertrophy, they get bigger, and they work overtime to try and compensate for the lost function. They undergo what we call adaptive hyperfiltration.
That sounds like a good thing, though. Compensation is good, right?
It is, but only for a while. The problem is that this constant high-pressure workload, this hyperfiltration, is damaging to the remaining nephrons. It causes scarring and sclerosis within the glomerulus. It's like running a car engine at its red line constantly. For a while it works, but eventually the engine blows.
So the very process of compensation actually destroys the remaining functional units.
Precisely. This leads to what Guyton describes as the vicious circle of progressive renal loss. It's a downward spiral. The fewer nephrons you have, the harder the remaining ones work, and the faster they burn out.
And eventually, we reach end-stage renal disease, or ESRD. This brings us to probably the most important section for the anesthesia exam, the systemic effects of CRF. The source material emphasizes that this is absolutely essential. The examiner will look you in the eye and say, list the systemic effects of chronic renal failure.
And you must be able to do it without hesitation. It affects every single system in the body. You should structure your answer system by system.
Okay, let's do it that way. Let's start with the big one, the cardiovascular system.
Right. This is the most common cause of death in patients with renal failure. Hypertension is almost universal. It's driven by two things: massive volume overload and a chronically overactivated renin-angiotensin-aldosterone system.
And what does that hypertension do to the heart?
It leads to cardiomyopathy, specifically left ventricular hypertrophy, as the heart works against that high pressure. These patients also have wildly accelerated atherosclerosis. Their 50-year-old coronary arteries can look like those of an 80-year-old.
And there's also pericarditis.
Yes, uremic pericarditis. It's a sign of severe undertreated uremia, and it's an absolute indication for urgent dialysis. On examination, you might hear a very distinct pericardial friction rub.
Okay, hematological. This is huge for us in anesthesia.
Absolutely. Two main things. First is anemia. It's a classic normochromic normocytic anemia, and it's primarily due to the diseased kidney's inability to produce the hormone erythropoietin, or EPO.
And the second thing, the one that gives us nightmares.
The bleeding diathesis, the uremic coagulopathy. And this is a common Viva trap. The examiner will ask you what the PT and PTT look like.
And they're usually normal, right?
Exactly. That's the trap. The coagulation factors are normal. The problem is with platelet function. Uremic toxins in the blood essentially coat the platelets and prevent them from adhering to each other and to the subendothelium. So you have a prolonged bleeding time, but a normal clotting profile.
Which makes planning for regional anesthesia incredibly tricky.
Very. We will definitely come back to that. It's a major consideration.
Okay, next system. Respiratory.
Think uremic lung. It's a form of non-cardiogenic pulmonary edema. You get increased capillary permeability, particularly around the hilum of the lungs, which on a chest x-ray can give a classic bat wing appearance. You can also see uremic pleuritis.
And the central nervous system. CNS effects.
Uremic encephalopathy. It's a spectrum from mild confusion and lethargy all the way to drowsiness, seizures, and coma. You also see a significant peripheral neuropathy. Patients complain of restless legs or have decreased sensation in their feet. This is important to document preoperatively, so a new deficit after a block isn't automatically blamed on the anesthesia.
Good point. And finally, the bone and mineral system. This seems quite complex.
It is. The umbrella term is renal osteodystrophy. It's a multi-step process. The kidney can no longer perform the final step in activating vitamin D. Without active vitamin D, you can't absorb calcium from the gut, so blood calcium levels start to fall.
And the body responds to that low calcium.
It does. The parathyroid glands sense the low calcium and go into overdrive. This is secondary hyperparathyroidism. They start pumping out parathyroid hormone, which strips calcium from the bones to try and normalize the blood levels. The result is that the bones become weak, brittle, and prone to fracture.
It really is a complete multi-system disaster. So let's take this very complex patient to the preoperative assessment clinic. We're seeing them a week before their surgery. What are the absolute key things we are looking for?
You're looking for stability and optimization. The first and most important thing is their volume status. Are they fluid overloaded? You need to look at the jugular venous pulse, listen for crackles at the lung bases, check for peripheral edema, and you must compare their current weight to their established dry weight after their last dialysis session.
And the dialysis history itself is crucial.
Absolutely essential. You need to know the schedule, what days of the week, and most importantly, when was their last session. Ideally, it should be within 24 hours of their planned surgery.
And why is that timing so important?
It's a balancing act. If you do it too soon before surgery, say just a couple hours before, they might still be anticoagulated from the heparin used in the dialysis circuit, and they might be quite hypovolemic from the fluid removal. But if you wait too long, say 48 hours, they'll be coming to the OR fluid, overloaded, hypertensive, and dangerously hyperkalemic.
And we also need to know about the AV fistula.
The lifeline, that's what you call it. You must document its location, check for a palpable thrill and an audible bruit to confirm its patent. And you need to write in big, bold letters on the chart, NOBP cuffs, NOIVs, NO arterial lines in the fistula arm. You have to protect it. If you thrombose a patient's only access for dialysis, you have caused a catastrophic complication.
Okay, let's talk labs. What are our red line cutoffs for proceeding with surgery?
Potassium. Potassium is the big one. Ideally, you want the serum potassium to be less than 5.5 milliequivalents per liter. If it's creeping up towards 6, you are taking a huge risk of intraoperative arrhythmias and cardiac arrest. The surgery should be postponed for dialysis.
What about hemoglobin?
Hemoglobin is almost always low. A level of 6 to 8 grams per deciliter is common and generally well tolerated in these chronically anemic patients. We tend to accept that unless they have significant active ischemic heart disease where they might need more oxygen-carrying capacity.
Okay, so we've assessed the patient. They're optimized as much as possible. Now for the day of surgery, anesthetic management. Let's start with the general principles.
The two overriding goals are simple to state but can be hard to achieve. Goal 1, maintain renal perfusion at all costs. Goal 2, avoid any and all nephrotoxins.
For perfusion, that means maintaining MAP, right?
Yes. The rule of thumb is to keep their mean arterial pressure within 20% of their baseline preoperative reading. For a chronic hypertensive patient, their normal MAP might be 110. Letting it drift down to 70 is a recipe for acute on chronic renal injury. Hypotension is the absolute enemy.
And what about fluid management? This is always a source of debate.
It is. It's the Goldilocks approach. You can't give too little because you'll cause a pre-renal injury, but you can't give too much because they can't excrete the excess fluid and you'll push them straight into pulmonary edema.
And the type of fluid? Saline versus ringers.
The traditional exam-safe answer is to use normal saline because it doesn't contain potassium, whereas Ringer's lactate does. However, the modern understanding is that large volumes of saline can cause a hyperchloremic metabolic acidosis, which itself can worsen hyperkalemia by causing a potassium shift out of cells.
So what's the best answer now?
The most nuanced answer is that a balanced salt solution, like Plasmolite, is often preferred. But for the purposes of a straightforward exam answer, stating you'd use normal saline cautiously, especially if potassium is a concern, is a very safe and defensible position.
Okay, now we enter the pharmacology zone. This is where the viva can get really intense, the effect of renal failure on anesthetic drugs. Let's start with the induction agents.
Right. Think about propofol or thiopentone. In chronic renal failure, patients are often malnourished and have hypoalbuminemia. Less albumin protein means less drug binding. This increases the free fraction of the drug, the active portion.
So the same dose is going to have a much stronger, more profound effect.
Exactly. Plus, the uremic state can make the blood-brain barrier more permeable. So the bottom line is you must reduce your induction dose and titrate it very carefully to effect.
Opioids. You said earlier this is a minefield.
It absolutely is. The examiner will be sitting there waiting for you to say morphine.
And I should say.
Absolutely not. Avoid morphine at all costs. You have to be able to explain why. Morphine itself is metabolized by the liver, but it's metabolized into morphine 3-glucuronide, M3G, and morphine 6-glucuronide, M6G. Both of these metabolites are excreted by the kidney.
And in renal failure, they accumulate.
They accumulate to toxic levels. M6G is a very potent opioid agonist, even more potent than morphine itself, and it causes profound and prolonged respiratory depression. You can have a patient who seems fine in recovery, but then hours later they become re-narcotized as M6G levels continue to climb.
What about pethidine, or meperidine as it's known in the U.S.?
Even worse, if that's possible. It's metabolized to normoperidine. If normoperidine accumulates, which it will in renal failure, it's a powerful neuroexcitant. It lowers the seizure threshold and can cause tremors, myoclonus, and frank seizures. It is absolutely contraindicated.
So what are our safe choices? What do we use?
Fentanyl is a very safe choice. It's metabolized by the liver into inactive metabolites that don't accumulate. Remifentanil is also an excellent option because it's metabolized by non-specific plasma esterases, making its clearance completely independent of both liver and kidney function.
Perfect. Let's move on to muscle relaxants. This is another classic Viva question. What is your muscle relaxant of choice in a patient with end-stage renal disease?
The textbook and correct answer is Cisatracurium, or its parent compound, Cisatracurium.
And the reason is Hoffman elimination.
Precisely. You must use that term. Hoffman elimination means it breaks down spontaneously in the plasma at physiological pH and temperature. It doesn't need the kidney or the liver to be cleared. Its duration of action is completely unchanged in renal failure.
What about the aminosteroid relaxants like rocuronium or vecuronium?
They are usable, but with extreme caution. A significant portion of their clearance is via the kidneys. So in renal failure, their duration of action will be significantly and unpredictably prolonged. If you give a standard dose of rocuronium to an ESRD patient, they could remain paralyzed for hours. You must use a nerve stimulator and titrate very small doses.
And now for the elephant in the room, succinylcholine, the big trap. The examiner looks at you and asks, can you use scoline in a renal failure patient? Well, the knee-jerk, panicked answer from a student might be no, because of hyperkalemia.
And that would be the wrong, or at least an incomplete answer. The safe, nuanced answer is, yes, it can be used. If the pre-induction serum potassium is confirmed to be in the normal range, let's say below 5.5, and the patient does not have any other contraindications like a uremic neuropathy.
Can you explain that a bit more?
Of course. Succinylcholine raises the serum potassium by about 0.5 to 1.0 milliequivalents per liter in every patient. If your patient starts with a potassium of 4.0, they'll go up to 4.5 or 5.0. That's perfectly fine. But if they start at 5.8, you're going to push them up over 6.5 and risk a hyperkalemic cardiac arrest.
So the absolute potassium level is the key. What about the neuropathy part?
If a patient has a significant uremic neuropathy or has been immobile and bedridden for a long time, their muscles can develop an upregulation of extrajunctional acetylcholine receptors. When you give succinylcholine to these patients, you can get a massive life-threatening release of potassium. So the bottom line is, it's not strictly contraindicated, but you must use it with extreme caution and only in the right patient.
That is a crucial nuance to understand for the exam. Okay, let's focus specifically on dialysis and anesthesia. We mentioned the ideal timing is about 24 hours prior to surgery.
Yes, that's the sweet spot. It allows for correction of fluid overload and electrolytes without leaving the patient hypovolemic or anticoagulated on the day of surgery.
What are the absolute indications for preoperative dialysis? There's a mnemonic for that, isn't there?
There is, and it's very helpful. AEIOU.
Yeah.
A is for acidosis, specifically a severe metabolic acidosis that's refractory to bicarbonate therapy. E is for electrolytes, most importantly, life-threatening hyperkalemia.
I is for.
I is for intoxication. This is for removing certain dialyzable drugs or toxins like aspirin, lithium, or methanol. O is for overload, specifically fluid overload causing pulmonary edema. And U is for uremia, meaning symptomatic uremia with signs like encephalopathy, pericarditis, or severe bleeding.
AEIOU. Clear and concise. So moving into the intraoperative management phase, what specific monitoring do we need?
Beyond the standard monitors, invasive arterial blood pressure monitoring is highly recommended. These patients have very labile blood pressure, and you need beat-to-beat information to manage it effectively. A central venous pressure line can be controversial, but looking at the trend of the CDP can be more useful than a single number to guide fluid therapy.
And throughout all of this, we are protecting the fistula arm.
With your life, you need to pat it, position it carefully, and constantly ensure there's no pressure on it from retractors, surgical assistants, or anything else.
Okay, the surgery is over. Post-operative management. What are the key concerns for pain control?
Multimodal analgesia is the best approach, but with one massive caveat. Absolutely no NSAIDs.
Right, because NSAIDs like Toradol or diclofenac inhibit prostaglandin synthesis. And in a compromised kidney, prostaglandins are vital for maintaining afferent arteriolar vasodilation and renal blood flow.
Exactly. Giving an NSAI to a patient with renal dysfunction is a fantastic way to fail your exam, and more importantly, to cause significant harm to the patient by precipitating acute renal failure. Stick to opioids like fentanyl, small titrated doses of hydromorphone or paracetamol. Regional techniques are also excellent, provided it's safe from a coagulation standpoint.
Let's talk about the most feared perioperative complication, hyperkalemia. We need to be able to walk through the ECG changes. This is a classic draw this for me question in Aviva.
It is. You should be able to sketch it out. The very first sign is the development of tall, peaked, tent-like T waves. As the potassium level continues to rise, the PR interval becomes prolonged. Then the P wave starts to flatten and eventually disappears entirely.
And after the P wave is gone.
Then the QRS complex begins to widen. It spreads out. And the end game, the pre-arrest rhythm, is the sine wave pattern. The widened QRS merges with the T wave to form a smooth, undulating sine wave. This immediately precedes ventricular fibrillation or asystole.
So, you're in the OR or the ICU, you see those peaked T waves appear on the monitor. What is the emergency drill?
There is the three-step drill you must recite instantly. Stabilize, shift, and eliminate.
Okay, step 1, stabilize.
This is the most urgent step. You give IV calcium, either calcium gluconate or calcium chloride. It is critical to state that this does not lower the serum potassium level. What it does is stabilize the cardiac membrane potential, making it less excitable and protecting the heart from arrhythmia. It works within minutes.
Step 2, shift.
And you want to temporarily drive the excess potassium from the blood into the cells. The most effective way to do this is with an infusion of insulin and dextrose, typically 10 units of regular insulin with 50 milliliters of 50% dextrose. You can also use beta agonists like a salbutamol nebulizer and give sodium bicarbonate, especially if the patient is acidotic.
And finally, step 3, eliminate.
Now you need to get the potassium out of the body for good. This can be done with loop diuretics like furosemide, but only if the patient is still able to produce urine. You can use potassium-binding resins in the gut like kayexalate, but ultimately, the definitive treatment to remove potassium from the body is dialysis.
Excellent. Let's do a quick-fire comparison. ARF versus CRF. The examiner puts a scenario to you. A patient is brought into the emergency room comatose with a creatinine of 8. How do you know if this is an acute or a chronic problem?
Number 1 is history. Do they have previous lab results?
Yeah.
A single high creatinine is a snapshot. You need the trend. But without that, you look for physical clues. Look for severe anemia. That takes months to develop due to lack of EPO, so it suggests a chronic process.
What else?
Get an ultrasound of the kidneys. In CRF, the kidneys are typically small, shrunken, and echogenic on ultrasound, reflecting chronic scarring. In ARF, they are usually normal-sized or even enlarged due to inflammation and edema. And finally, look for evidence of renal osteodystrophy or severe secondary hyperparathyroidism. Bone disease takes a long time to develop, so its presence points strongly towards CRF.
And the most fundamental difference.
Reversibility. ARF is potentially reversible, CRF is not.
Before we wrap up, let's hit some of those Viva traps, the common mistakes that students make under pressure.
Let's do it. Trap number 1. The patient is oliguric intraoperatively. Should you give a dose of Lasix?
The temptation is always there to say yes, to try and kickstart the kidneys.
And that is the wrong answer. Your first answer must always be, first, I must assess the patient's volume status. Oliguria is most often due to hypovolemia. Giving a diuretic to a dry patient will only worsen the renal injury. You must rule out hypovolemia with a fluid challenge first. Furosemide does not prevent AKI. At best, it only converts an oliguric failure to a non-oliguric one. It makes the chart look better, but doesn't improve patient outcomes.
Trap 2. You mentioned this before, but it's worth repeating. Interpreting the FANA in a patient who is already on diuretics.
A great one. Diuretics, by their very nature, force the kidneys to excrete sodium. So the FANA will be high, probably greater than 1%, even if the patient is profoundly hypovolemic and has a pre-renal injury. The test is invalid. In that specific situation, you can mention looking at the fractional excretion of urea or furia, which is not affected by diuretics.
Trap 3. A patient with CKD needs a CT scan with contrast.
You must have a plan to prevent contrast-induced nephropathy. This involves aggressive pre-procedure intravenous hydration. The use of N-acetylcysteine is controversial, but hydration is proving to be protective. And you should advocate for the use of low-osmolar or iso-osmolar contrast agents.
This has been incredibly high yield. To finish, let's summarize the structure for that 20-mark written answer.
Absolutely. If you're writing this out, you should have clear headings.
Introduction and definition. Define AKI using the Rifle or KDIGO criteria, and define CKD with the crucial 3-month time frame.
Classification of AKI. Pre-renal, intrinsic, post-renal, with examples.
Pathophysiology. Describe the ischemic cascade for AKI and the hyperfiltration theory for CKD.
Systemic effects of CRF. Go through it system by system. Cardiovascular, hematological, CNS, etc.
Anesthetic management. Break this into preoperative, intraoperative, and postoperative sections. Talk about assessment, drug choices, monitoring, and pain management. And finally, a short conclusion, emphasizing the need for a multidisciplinary approach.
And for the Viva, the top 3 take-home points.
1. Know your pharmacology cold. Cisatracurium and fentanyl are your friends. Morphine and NSAIDs are your enemies. 2. Know the hyperkalemia treatment algorithm by heart. Stabilize, shift, eliminate. And 3. Respect the fistula. Always.
It sounds like the overall message is that the kidney is smart, but it's incredibly unforgiving.
That's the perfect way to put it. Respect the physiology, be meticulous in your management, and you will pass the exam.
Thank you so much for this comprehensive review.
Yeah.
I feel much more prepared. And for everyone listening, practice drawing those flowcharts, the AKI classification, the systemic effects of CRF, and especially the hyperkalemia ECG changes and management algorithm. That makes a huge difference when you're under pressure in the exam.
Absolutely. Visualize it, practice it, sleep well, and study hard.
We will see you next time on The Deep Dive.